discussion around comprehensive vision evaluations. What does your child need? And I have the pleasure of introducing Dr. Linda Lawrence. Dr. Linda Lawrence established a solo private practice in comprehensive ophthalmology with pediatric emphasis in Salina, Kansas in 1986. She performs functional vision assessment and outreach services. She's also a volunteer consultant for Centro and Sullivan del Peru in Lima, Peru, an educational NGO for students with neuro-developmental disabilities. Among her many accomplishments, she's co-authored a book chapter on pediatric low vision and is a member of the Pediatric Epilepsy Surgery Alliance's Scientific Advisory Board. And to learn more about Dr. Lawrence, you can look in your Sketch app to read her full bio. But I will turn it over to you, Dr. Lawrence. Thank you.
Thank you. It's really a pleasure to be here with you. And although the title is comprehensive, I'm sure there's a lot of stuff I left out. So if you could afterwards, I'm going to be around for a while. If you have some special questions or needs that we don't have time to answer, let me know, because that'll help me as I go forward to know what might be more important to you as providers and parents and students who may have some vision difficulties. So I'm from Salina, Kansas. It's if you remember the old Encyclopedia Britannica, it's the crack in the middle is where Salina is. So if you open the page to the U.S., we're right in the continental middle of the United States. And I've been working with the Kansas State School for the Blind for 20 plus years and in early intervention programs, almost 35 years, working with kids with brain-based visual impairment. So the teachers teach me and I teach them, and the parents teach all of us and the students. So I don't think anybody in this field is a real expert. We have a variety of eye care providers, including pediatric neuro-ophthalmologists, pediatric ophthalmologists like myself. I'm a comprehensive ophthalmologist, pediatric optometrists, low vision optometrists, that we all work together to try and provide the best service that we can. The slides that I'm using, in case you get a copy or whatever, they're not all my slides. I work with a lot of different people in this area, and some are from Dr. Gordon Dutton, who's an expert in the field of brain-based visual impairment. Some are from Terry Schwartz, who's at Cincinnati Children, and Sharon Lehman. So one of the things, can you guys hear okay? Is that? Just for a few terms, we have visual function, which describes how the eyeball functions. That would be visual acuity, the contrast, visual field, color vision. And then we have functional vision. Okay, functional vision describes how the person functions in vision-related activities. Very important, because when you go to your eye care provider, they're going to be doing all of these tests about the eyeball. They're looking at the eyeball, they're looking at the refraction, the motility, all of these things, but they may not address the functional vision. So sometimes we have to work in two different prongs, one to look at the actual medical part of the eye exam, refractive part, and the next is to look at the functional part. Not all ophthalmologists are comfortable with the functional vision, and sometimes that involves working more with a teacher of students with visual impairment, orientation mobility specialists who can add that piece, or a low vision optometrist. There's a big difference between adults and children with visual impairment, and that's related to development. Of course, you know, the younger you are, the more you have that developing brain, the more plasticity there might be that we don't fully understand. There is very little data on hemianopia in children, especially in regard to interventions. There's just a scoping review published just recently. I tried to get it, it was going to cost $400, so I didn't download it. But there is some information out there now, and the summary says basically that most of the data comes from countries who are high economic status, and most of them describe etiologies and causes of homonymous hemianopias, but not really interventions. So what we have to remember is children with congenital or early onset visual impairment or homonymous hemianopias develop functions and concepts based on an impaired picture, okay? And they may have a different image quality than we do, but they only know themselves to be normal. They don't know what it's like to to have a typically developing visual system. So if you tell them, well, you're not seeing out this side, they don't really know what you're talking about. So we have to be very sensitive to that. Versus like an adult who has a stroke and loses part of their visual field or homonymous hemianopia, they know, hey, I can't see over on that side. They remember what it was like before. So children's services have to be a lot different than adult services. And of course, they require complex multidisciplinary resources that are family and school-centered. So what about seizure disorders in general and visual function? The vision pathways may be already compromised by the underlying condition that causes seizures to begin with. So for example, if the child has an in utero stroke that takes part of the cortex or has cortical dysplasia, they already have a visual impairment even before they might have epilepsy surgery. Also, seizures can damage vision pathways. So if the child has uncontrolled seizures, they may have continuous damage to the visual pathways. In fact, we think seizure disorders are one of the most common causes of what we call brain-based visual impairment or cerebral visual impairment. I'm going to talk some more about that later. Genetic differences may contribute to the seizure disorder, also the formation of the brain, and cause some problem with visual responses. Also, medications that are taken for seizure disorders can contribute to problems with visual functioning, especially accommodation, where you have to look from distance to close up, and as you hit 40, for those of you who might be 40, it gets a little harder. Well, some of the medications that the children can take can cause that same effect, so we also have to be aware of what the medications are. Also, the medication called vigabatrin, which some of you might know about, that's most commonly used for infantile spasms, but also others can actually damage the optic nerve and the retina. Now, it's a tough choice. We used to examine children every 3 months who were on this medication to look for that damage and do ERGs. And I don't know if any of your kids were on it, but doing an ERG every 3 months is a little difficult. Plus, what are we going to do with the information? So what is commonly done now is the parents are given education ahead of time, and they have to make a choice. And usually what my experience is the neurologist put them on as short a time as possible until they get a better medication the next steps. So, and then of course we have surgery to treat the medically refractive seizures, and that can damage the visual pathways. So when we have epilepsy surgery that might consist of a hemispherectomy, what can happen? We can have problems with fields of vision, visual acuity, actual eye alignment with depth perception. We can have visual neglect that's different than a visual field deficit, and we can have problems with reading and literacy, plus a lot of other things. This is the data from your global pediatric epilepsy surgery registry, and I thought it was just interesting, and I don't know if you guys have seen this or not, but there were 185 hemispheric surgery participants. This just shows the percentage of eye-related disorders before surgery and after surgery. After looking at this database, we're probably going to redo it a little bit because it's a little bit confounding. For example, amblyopia. How many of you know what amblyopia is? Okay, so amblyopia is what we call lazy eye, which means that there's poor vision in one eye for a variety of reasons. It can be because there's a cataract. It can be because the prescription's off or the eye turns. The eye, from when you're born, has to give direct input that goes back into the brain. You see in the visual cortex in the back of the brain. After you are storing that information there, then you have to retrieve it through the temporal parietal and frontal lobes to use it. So if you think of your cell phone taking the picture, your eye is like the cell phone. You have to have a good clear lens. You have to have everything working and lined up just properly. It can't be dropped in the water or broken or cracked screen. You have to have a good picture taker. That's your eyeball. So as ophthalmologists, we typically concentrate on the eyeball. Do we have a good picture taker? Then those messages go back into the back of the brain, and if you think of your cerebral cortex as being the hard drive. So all those pictures are stored. But then, great, it's stored in there. What do you do with that picture? You want to retrieve it, send it to your family, put it in a PowerPoint, look at it again. You want to do something with that picture. And that's all the other processing in your brain, the temporal lobes, the parietal lobes, the frontal cortex. So the visual cortex needs continuous input of vision to properly develop. So if one eye is blocked off for whatever reason, it's out-turning, the brain ignores it. It has a cataract, the brain ignores it. It's not properly given the proper glasses, the brain ignores it. That part of the brain doesn't develop, and you don't get it back. So in a sense, you have brain damage from lack of use of the eye. Really important because that comes into play when we think about some of the things we see following brain surgery. So in this series, amblyopia before the surgery, you can see is maybe, 7-8%, and after is 20%. Now, what we don't know is the timeline of that. Were these all small children who were going to have amblyopia anyway, or was it directly due to surgery? So kind of look at this with a little bit of grain of salt. Strabismus, which is misalignment of the eyes. The misalignment can be turning out, turning in, turning up. Those are all different ways. Those are all called strabismus. In is esotropia, out is exotropia, and we can have hypertropias, hypotropias. So there's a lot of different ways that the eyes can not work together. And as you see in here, I don't know if this pointer comes on or not. Yeah. Strabismus did seem to increase after surgery. So again, is that something that would have happened anyway because of refractive errors or because of amblyopia or because they had an intermittent exotropia that became more, there's a lot of reasons. So I'd like to in the future, we might be asking those of you who might be in the registry to give us some more information in those areas so we can better clarify it. Nystagmus is when the eyes move usually in a rhythmic manner, although there is what we call sensory nystagmus in a child who might be blind, in the sense not have hardly any vision, and it's more of a random, kind of a searching type of movement of the eyes where the eyes are looking around a lot, or there can be more of a rhythmic nystagmus. Some kids are born with that. Sometimes we see it in people with seizure disorders. It's very common in Down syndrome. So that doesn't cause the vision to move, it just causes a blur. Okay, so cortical or cerebral visual impairment, we only see 20%, and this is again kind of doesn't really match up because if you look down, the next thing is homonymous hemianopia is 80%. Now, technically, if you take out the occipital lobe and part of the parietal lobe, that should be 100%, right? So again, something we need to look at. And if you have homonymous hemianopia, by definition, you have CVI or brain-based visual impairment. So CVI should also be 100%. So I'm going to be maybe asking some of you guys for further information. What we don't know is just that it hasn't been diagnosed properly. You haven't been to the right person who understands CVI. Just to tell a little more about CVI, our paper from the NIH was just accepted to be published on the diagnostic criteria for CVI just today in ophthalmology. So it's going to be out there. Yeah, it's been a lot of work by a lot of people. It's great because those of us who have been in this field for 20 plus years have been banging our head against the wall, like some other things that you guys probably have too, and finally to see at that level the recognition that yes, this is a problem, and yes, we need to do a registry, and yes, we need to do more research. It's very, very exciting. So I wanted to show you this very, very complicated slide because if you look here, this is the front of the eyes. The image comes in here, it hits the retina, goes down the optic nerve split and cross at the optic chiasm, which is right where the pituitary gland is. And then it goes down into the optic tracts, goes back into the hard drive here, and up into the temporal lobe. Now, depending on where your child's surgery was, that's going to affect the visual field. So it's kind of hard for me to say, oh, well, if this and this and this. We just need to look for it. And then we need to look for these visual field defects, knowing what the maybe preoperative was, knowing what the surgery was, and look for those defects to see what modifications need to be made for the environment or the school place for the children. So typically we think the greatest preserved field of vision is in the eye at the same side of the surgery. Now, you have to remember that this visual field loss is in both eyes. So it's really important. A lot of people, it's not intuitive. And, you know, we often have parents who say, well, they can't see on the left eye. I'm like, well, no, it's the left side of both eyes. And the thing is that the nasal part here is kind of masked by the nose. So, you know, if you cover up one eye and you see, well, my nose is in the way here, so I'm not seeing over that way very much anyway. Typically, your visual field will go 90 degrees this way and 40 to 60 this way, okay? So if you have a hemianopia, you're gonna have half gone here, and then over here, you'll have half gone. So, anyway, so what should you do as a parent when you know that first of all, if your child has a seizure disorder, they need to have an eye exam. The earlier the better. We can check kids in the NICU, we can check kids in early intervention, we can check kids at any age. If you go to an ophthalmologist or an optometrist who's not comfortable checking a small child, they're out there, find another one. I mean, there are people out there who can do that easily. These are the tools we commonly use in the birth to 3 arena. We can do grading acuities, which doesn't give an actual acuity, but there's a norm, and then we can check that child against themselves to watch for progression in acuity. So we can't say they're 20/20 or 20/30 or whatever, but we can evaluate them and check them against themselves. There are teller cards that give you a more closer to what an actual visual acuity would be, like 20/30 or 20/40. And the visual acuity is how small a thing they can see. These cards here are called Height and Heidi. They're a contrast card. So we can actually, we put a white card up in the face card, and we see if the child looks at the large black and white card. And we go to lower and lower contrast, so we make the black less and less. And when this is 25%, when we get to 5%, which is kind of faint, that's about the contrast of a human face. So if I'm able to do that and the child sees it, I can then, I'm going to step off here, but I can move back, and then I can tell the parents, well, you know, at about 6 feet, your child can probably see your facial details. Or no, you better get up about 6 inches if they're going to be able to see your face. So we have a variety of things like that to check acuity. We need to check refraction on every person, okay? That's so important. Do they need glasses or not? The indications for glasses wear in children with neurodevelopmental disabilities is way different than a typical child. So often you might hear, well, they're prescriptions within normal for age. These are not typical kids. The guide for when to give glasses was based on a consensus opinion in 1996 by about 60 ophthalmologists, and it's just stuck there. And so remember, your child has special needs. They may benefit from glasses in a different manner than another child who doesn't have those needs. Pupil exams normal, you know, are the pupils reactive? You know, if there was a tumor on one side or some problem, the pupil might not react normally. We look at the outside, do they have eyelid drooping? We look at the front part of the eye. You know, often kids can have other eye diseases, you know, that go along with their seizure disorder, especially if they have some kind of syndromic seizures. We look at the alignment and motility. Are the eyes straight? Do they turn in and out? Do they work together? Do they converge normally? Is there a gaze palsy where they can't even look to one side? Or there muscle paralysis? All those are important things even to look at before the surgery, so you have a nice baseline. And then, of course, we always dilate the eye and look inside. You know, we want to look at the optic nerve. Is it healthy? And the retina. This is back to those LEA. These are called LEA gratings. There's different kinds, but you can see there's a white paddle put in front of the stripes, and the stripes get thinner and thinner and thinner. And then this is just a plot here that shows at what age they should see a certain line of stripes. So it's just one of the ways we can look at acuity. And this is a study out of Italy where Dr. Ritchie, who's a pediatric neurologist, has been able to measure the vision in babies in the NICU at 32 weeks gestation. So somebody says, it's too early, we don't know how to do that. That's not right. We know how to do it. We know how to do it. So And then the other thing we do is as the child gets older, we start doing matching games if they have the age and ability to do that. And then we use these symbols that are called layout optotypes to actually check an eye chart. So they don't have to even know what it is if they can match. So one of the things I always do in my office is I start teaching very early how to match. And matching is a basis for communication. So it's a good skill to know. So puzzles, and starting with puzzles and matching, or functional matching. Are those your two shoes? Which shirt goes with which skirt? These things you can teach in the home. So I'm going to talk a little bit about glasses and refraction because I think this is way, way underemphasized. And I think too often a family is told that, well, either they're not going to benefit from glasses or they're within normal for their age. So we use glasses for a lot of different reasons. Some children can see without their glasses. And the glasses are not there just for vision. They may be to treat other underlying eye conditions. For example, we were talking about amblyopia. If you have one eye that's different than the other eye and you don't wear the proper glasses, they can lose the vision in one eye. And you won't even know it because they're seeing out of the other eye. So pretty soon you can have amblyopia complicating a homonymous hemianopia. So they can lose further vision. So checking that, especially under 7. After 7, we usually feel like we're probably okay. So one thing, if they say there's a difference in the two eyes, you really need to be on top of that because we don't want to lose vision that's treatable and preventable. To correct strabismus, or we talked about eye crossing. This is a little girl. You can see her eyes are turning in here. This eye is turning in. With the proper glasses, these are for farsightedness, the eyes are straight. So she doesn't need eye muscle surgery. There's nothing wrong with her eye muscles. The problem is she has to focus so hard because she needs this prescription that turns her eye in. When you turn the eye in, what does the brain do? Oh, I'm seeing double. If you cross your eyes, imagine how you could walk around. Everything's disrupted. So the brain goes, I'm just going to shut that eye off. So then what happens? Brain doesn't get the input, the occipital lobe doesn't develop, and you lose the vision in the eye. So strabismus and amblyopia are very closely related. A lot of people call this lazy eye, but that's not a very good term, but that may be the term you've heard, but we like amblyopia and strabismus. Many of our kids with neurodevelopmental disabilities or seizure medications have trouble accommodating. We talked about that. They may need a prescription at a lower amount of prescription than a child who doesn't have that. So it needs to be evaluated. I can say most ophthalmologists do not evaluate that. It's just not part of our regular exams. So it has to be a separate exam when they're not dilated and when they have their glasses already. So it takes a lot of time and effort for everyone to do that, but it's so worthwhile to check that because sometimes children need a bifocal or stronger reading glass, and that can help a lot with their ability to access materials for literacy. Sometimes we need thick glasses that magnify because a child has low vision, and they'll be helpful. Sometimes for photophobia, if the child is really, really sensitive to light, we can use transition lenses or a tinted lens, and I have a lot of kids who have to have that to they're going from the classroom outside, and they don't want to be changing into sunglasses, and so they wear transition lenses. There are kids who benefit who have homonymous hemianopia from what we call yoke prisms. I personally don't fit those. I have a low vision optometrist who does. We've had variable success, but that might be recommended, and it's something to try and ask them what their success is. The thought is that it moves the image over, but it's variable. And then for some muscle imbalances also, there might be prism glasses used. So the main thing I want to emphasize is you should know why your child has the glasses. Is it just to see far away? Is it because they can't focus up close? Is it to prevent loss of vision? So all those things are important. I hear so often, well, my child doesn't like their glasses. No child likes their glasses. I mean, most adults don't like their glasses, so they might take them and throw them off, and they don't know that it's a medically necessary thing. So you have to be gentle and kind. And I had one mom who for 2 days just said, glasses on, glasses off, glasses on, and finally the child started wearing the glasses. So there's different techniques, and it's not easy, but something we have to do. And again, I want to mention again dynamic retinoscopy. This is how we evaluate for poor accommodation. And if you go into the ophthalmologist, you need to ask them, did you check, can they accommodate? It's really important. So the comprehensive eye exam, then, we're looking at, here's the eyeball, very complicated little picture taker. Anything can go wrong in any layer with anyone. So whether you're a child or an adult, we can have childhood cataracts, we can have childhood retina diseases, childhood optic nerve problems. So we have to be sure that the eye's healthy and that we've done everything we can to improve or take care of that eye health. And then here's the eyeball here, and look, there's 1, 2, 3, 4, 5, 6 different muscles per eye where something can go wrong, okay? And most of those eye muscles are controlled by what we call the third cranial nerve. So sometimes if there's an in-uterine stroke, that can be affected. There's just one here, the superior oblique, that's controlled by the fourth cranial nerve. And then the sixth is the lateral rectus. Now in hydrocephalus, the sixth nerve can often be affected. So if your child's had surgery for epilepsy and there's hydrocephalus, it could present as eye turning. So if you see eye turning that's sudden, you should contact your doctor and have that checked out. So just a little caveat there. And really what we want to know, everything is a spectrum. The child's not a diagnosis. We got to look at everything. We got to look at whether their visual impairment was acquired or congenital. When did it happen? The history is so important. We want to know if it's progressive or not progressive, right? We want to know if it's what we call ocular visual impairment, which is eyeball related, or if it's brain-based, or what we call cerebrocortical visual impairment. And remembering all along that these can all coexist, and they can all coexist with other systemic challenges. Uncorrected refractive error is one of the largest causes of blindness in the world. So don't forget to have your eyes checked of your child, especially if you have high myopia yourself. And remember that trauma, tumor, infections, toxins, genetic, metabolic can affect any part of the system, from down here to the retina, the 12 intricate, complicated layers of the retina, to the cornea, the lens of the eye, the vitreous, the retina, the optic nerve, and anywhere in the brain. So it's a very complex system. So our typical eye exam then, when we know a child has a neurodevelopmental delay, is that we'll often look for what we call CVI, or cerebrocortical visual impairment. And there's different ways to do that. I think if you talk to different ophthalmologists who do this work, we all have our little bit of differences. We rely a lot on our teachers of the visually impaired who are also doing a functional visual evaluation on the child, and that communication is super important. So these are a lot of list of things we might look at. Saccades and pursuits, how do they move their eyes across the page? We can do some other tests like, do they understand direction, contrast sensitivity, color vision. Color vision is usually not checked in the typical office of an eye care provider. We check 100%, but just because I think it's important. Sometimes a visually evoked potential is advised, or an electroretinogram. Those are two tests that are done more in larger centers. So since I live in rural Kansas, we don't have access to those, so I've just learned how to not use them. But if you're in a bigger center, they may say, hey, we'd like to do this test. And it's just to give them an idea of the function of the visual system. Now, the function of the visual system, but not the functional vision. So if you get an ERG, an EEG, a VEP, a CAT scan, an MRI, and it comes back and it says your child has CVI, they still need that functional evaluation. You can't diagnose CVI based on an MRI scan, nor do you need an MRI scan to diagnose that. But in our case, most of our kids would have MRIs, and it is helpful. So I really want to emphasize this again, that homonymous heminopia is a brain-based visual impairment, and that means it's considered cerebral or cortical visual impairment. Now, why is that important to you? Because in most states, that opens up resources. The definition of blindness is moving from just 2200 in each eye, or a 20-degree visual field, to functional visual impairment. So neurological visual impairment that's brain-based, is now considered a visual impairment, and in many states, at least I know in Kansas, it guarantees access to teachers in the school and special evaluations and special resources and money for things that can be very helpful to your child. It doesn't mean they have another diagnosis. I mean, just what you want, right, is one more diagnosis. But remember, this opens services for you. And I want to, after our talk yesterday with the audiologist, don't forget about hearing too, because if they have a central hearing processing disorder plus CVI, that opens up deaf-blind funds in your state. And some of the good things our Congress does, if you want to thank them, is help support the deaf-blind funds and also the American Printing House, which helps with materials for our kids who have visual impairment. So they allocate money every year, which is awesome. So how do we test visual fields then? And say, well, okay, it's age and ability dependent, and we can't always do it. So we try our best. If we do what we call confrontation, which is look at my fingers here, count my fingers, you know, kids are pretty tricky. You know, they might see your arm, or if you have two people, you know, they might feel where you are, and so they'll look, and you're like, well, I don't know, did they really look, or did they not look? So you have to be pretty tricky. Humphrey Visual Fields is an automated machine. It takes about 5 minutes an eye. So, I don't know, most of my adults struggle with it, let alone the kids, but we do try that in older kids. I want to make a case today for optical coherent tomography that takes 7 seconds. I'll show you some pictures. Again, it's age and ability dependent. The child has to be able to sit in the machine for about 7 seconds and look at something. So we start training them very early at about 5 or 6, and we just bring them in the machine and say, we're going to do this. And you know, we usually don't get a picture, but down the road we can get a picture. And then also in Kansas, we use eye gaze technology. We just presented this at the AER conference. It's the national conference for TBIs and people who work in the vision field, orientation mobility specialists. I don't know, they were really excited, so you might see this pop up, and I'll explain what that is. So in CVI or in any damage to the parietal lobe, we can see hemiattention, which is more of a neglect, versus a heminopia, which is an actual visual field deficit that we can map out. So they look the same a lot of the time, so I don't know. I'm going to skip through that because I don't know how important that is. It gets kind of complicated, but mainly in heminopia, this little girl is looking straight, and she's trying to find, so this is the side that she has a heminopia on. She's trying to find the white spot. She can do it by turning her head, but by just turning her body and keeping her head straight, it doesn't help. In a neglect, if you turn your body, it helps. So I don't know, if you have a kid and you're not sure, like your child or your teacher in the school, you might try both a head turn and a body turn, because I think it's very difficult to make that distinction at our level. There are some compensatory strategies to maximize the visual field, or is thought to. There's variable feeling about this, but you might hear this, that an intermittent or constant exotropia or eye turning out may help to maximize the visual field. Now, what worries me is that when we have young kids who have an exotropia, guess what's going to happen? They're going to ignore the vision in the eye, the central vision, and develop amblyopia on top of that. So they're actually going to lose the vision in the eye that's deviating. So I don't think the word is really out on how that should be treated. So if your ophthalmologist says, well, that eye's turning out to compensate for the visual field, ask them, are they going to lose vision in that eye? Should we be doing some eye patching of the stronger eye to make that eye at least come in for part of the time to encourage the vision to develop? It's a little tricky question. I don't think there's any right or wrong, and that's why I want you to have this information, because then when, if your doctor says, well, it's okay, it can just turn out and your child's 3, you know what, they're going to lose vision in that eye, and that's not all right. So also, you'll often see a child with a face turn and a gaze difference. Let them do it. If they can compensate and see better that way, just let them do it. And then when they're older, we can decide, well, sometimes like if it's from nystagmus, we can move the eyes to the midline and give a better midline look, but that's a compensatory thing. So you don't want to be straightening their head. You want to let them compensate the best they can. We also think that there can be some persistent vision in the absent field. Again, these are studies that are out there. I don't think it's going to be that applicable to all of us. I would like to invite you to look at CVI Scotland website. They have a simulation of homonymous hemianopia, and it'll give you another idea on what it might look like to your child. Again, it's going to be different for every child based on how they compensate and other things that go on, but it's really very nice to give some ideas. Now, OCT, optical coherent tomography, I don't know how for time here. Okay, is a special test. It uses infrared technology. There are no norms for kids. It's technically difficult in kids because they might have nystagmus, fixation problems, different positioning. They have a handheld for adults. It's built for adults. Most of your pediatric ophthalmology departments don't have this because it's built for adults, and the handheld are very expensive. They might use it if they're doing research on premature infants. So they're going to have to take your child over to the adult section to do the test in most cases, which makes it cumbersome and another trip, and who's going to pay for it? There's no codes to pay for it, so it's very complicated. Luckily, I have one in my office, so all of my kids get one. I take care of adults and children, so I've learned a lot from doing serial OCTs. So what happens is if we have an injury in the brain, remember those nerves, say this blue here, this is the visual field, this is the part of the retina that perceives it, goes back here into the back of the brain. Now, if there's a cut here, anywhere in here, guess what happens? Those nerves don't have anything to attach to. So what happens to them? They die. So we get retrograde degeneration of the optic nerve and the ganglion cells in the optic nerve. So we can see a child at birth and the optic nerve looks very healthy, and then all of a sudden it's getting what we call atrophic or whitish. And it's not because it's a progressive problem, it's just those nerves that never work are never working, and so they're just dying. So we see what we call optic atrophy. It's very interesting, and we can document it with the OCT. This is a confrontational visual field up here of a little guy I had who had a brain injury at 7 months old, and I was just doing my regular confrontation, and he had a left hemianopia. He was about 2 years when I got that. Here he is at 16. We were able to get a Humphrey visual field, so this is an automated field. Again, some kids can do this, some can't. And then this is the OCT, and can you see, this is actually, the little blue spot is the macula, where you get your 20/20 vision, the back of the retina. Here's the optic nerve is over on this side, and this is kind of where the concentration of those ganglion cell layers that give you the good vision are. It's half gone on that side, and it's half gone on that side. So that's a 7-second picture, if the child can cooperate. Here's another picture. This is a boy who had a midline craniopharyngioma. We know they get bitemporal field loss. Here's his Humphrey field. This black is where it's just gone. And you can see straight down here, it's gone. I use this to follow kids who have midline brain tumors, who have optic nerve gliomas. We can do it in kids who have seizures to look at their brain. It's a quick cheat test, quick, if they can do it. So the eye tracking, eye gaze is a functional tool that we developed in Kansas using the Tobii Dynavox technology. We just kind of bored their technology. It's not a visual field. We have no funding. We have not promoting any product. We just found that this is something that's very useful to us. There's an eye tracker on the bottom. It was developed, started as gamers, you know, and then those of you who work with augmentative communication, you might be working with an eye gaze system. And then we borrowed the speech-language pathology Look to Learn software because it was free. So we did all of this free. The child basically, here he is over here, looking, this is a tablet on a tripod. The eye gaze is down here. He's looking at the tablet, and he's looking at a variety of different video presentations that we put on there. It records all the looks, all the hits on that screen. So it records it. We also now we do a full recording, plus we have an iPhone where we're taking a picture of the child while they're doing the test, So we can look at head position, compensatory. But is there a gaze? Is there a shift? Is there a body turn? Do they scooch all the way over to the side of the chair? It's really interesting because then we can show that to the parent and teacher. Parents usually in the room, but the teacher we can show and say, okay, this is the compensation your child might be making, and it's okay. They're not just being bad and trying to slide off the chair. You know, it helps them to do this. So you can see in this little boy on the right side, see where this blue is? He didn't really do any hits over there. He didn't look over there. And where the red is, it's kind of like a weather map. The red is that's where he's seeing a lot of stuff. So so he has a definite preference on the left side there. So we can use that to help in the classroom. We can use that to have an orientation and mobility evaluation to see if that's affecting his traveling or safety or independence. Here's another little boy with infantile spasms who then had a procedure done, and you can see that all the hits here, the red, and there's a big chunk missing out here. Okay, and so it just helps us with modifications in the classroom and at home. Another boy who, and sometimes it gets kind of cloudy, like this boy had infantile spasms, which probably caused some brain injury. He had the gabapentin, so we don't know how that affected things, plus cortical thickening on the left. So the interesting thing about this is just the pattern again of the eye looking, and it's different, and sometimes it's not what you expect. Like you think if they have a left homonymous hemianopia, they're going to do something, and it's completely backwards. So it gives us an idea that maybe we're looking at the medical part and we're missing out on the functional part, because we're going to go, oh, the visual field says this, the visual field says this, but that may not be the way they're functioning at all. So in summary, what does your child need? I advocate for a pre-surgery comprehensive eye exam. OCT, visual field, color vision, all of that is age and developmental dependent. VP and ERG would be based on the center you're going to. Eye gaze and eye tracking is not readily available unless you live in Kansas. You can do it. Post-surgery, you need, again, an evaluation, continued evaluation, because your child's going to continue to grow and develop. So maybe they don't need glasses when they're 3 or 4, but they might when they're 8 or 9. So don't forget to continue with your comprehensive eye exams. Educational, of course, all your kids should have a formal functional visual evaluation with a teacher, the visually impaired, and consult with orientation mobility specialists depending on how much that visual field deficit may be affecting their safety and independence. We have kids, many of our kids use a white cane. I haven't really seen any kids here use a white cane. Do any of your kids use a white cane? Yeah, so we have, I think all 3 of my kids, the ones that I have, are all learning cane for independence and safety reasons. So be sure you get that orientation mobility specialist in there to look at that. And you can ask for that. That's your right as a parent. You can put that on the IEP, but you want that, at least a consultation. Vision services should be on your IFSP, which is birth to 3. I don't know, I think you guys are mostly familiar with this, but birth to 3 would be Part C. Those are early intervention services. There are teachers of the visually impaired and orientation mobility specialists who consult to those services. So don't think, oh, they're getting early intervention, that's fine. You ask for those vision services. And then the same when they go in Part B into the school setting. And if you're homeschooling still, I think a lot of states now, you're able to get those services even if you're homeschooling, so you got to ask for them. And there's other people who are also involved. As far as transition, Dr. Alex Bauer is doing a study, as you know, this week looking at kids who have had homonymous hemianopia as far as is driving safe. We don't know the answer to that. There's various, in my state, nobody knows. We're a rural state. In other states, they're very rigid about it. So it's just a question we don't know the answer to. How safe is it? We talked about blind deaf consortiums. Remember the terminology, this visual impairment interferes with access to education. That's what you need for your IEP. So that will get you at least an evaluation. This organization can help you advocate. Monica can get you where you need to be. Be sure your doctor understands the proper language in your area and who your team is, whoever is your main doctor. So in summary, we can see problems with visual acuity, alignment, visual neglect, field of vision, reading and literacy. And our role as ophthalmologists is to diagnose, to treat the underlying conditions, the ophthalmic problems, document medical necessity, refer, but you have to realize that we can't order services in the school. Education's here, medicine's here. I have a pretty good relationship with my schools, so they'll usually listen to what I ask for, but you as the parents can ask. And if you have an IEP, you can be very forceful about asking for vision services. Even if it's just a yearly consult, maybe your child's really doing pretty well visually, get that yearly consult. You know, be sure, because every year they're going to change. Each grade is different, each school's different, situations are different, puberty's different. I think that's about it. This book is on the website, and that's my email if anybody has any questions. I don't know if we have time for questions, but if we do, until they kick us out, and I'm also going to be, I'm happy to stay around for a while and answer any questions. Thank you for listening.